Welcome to Vilnius, Lithuania. Welcome.
Hello, good evening everyone, and of course good morning and good afternoon to these who are maybe in different time zones on different continents. My name is Hubert Golabek and I'm a member of the Communication and Engagement Committee of the ESE, and it is my great pleasure to spend this time with you to conduct the interview with a very special guest today, which is Professor Hal Duncan, the former president of the ESE. Hello, Hal.
Good afternoon, good evening, good morning, Hubert. Great to speak to you, and delight to be talking about the upcoming meeting in Vilnius. So hi, everybody.
I'm really honored to spend this time with you, and it is another live session from the ESC. In the topics that will be covered in Vilnius that you mentioned. Last live session was about the VPT, and today we will focus on another topic. We'll talk about mineralization, thinking beyond mineralization, and the title of our today meeting is Beyond the Bridge, Understanding Pulp Mineralization. So just to open, Professor Duncan, your research has consistently challenged us to think beyond materials and techniques and instead understand the biology that determines whether a pulp heals or fails. Today, I would like to explore what is actually happening biologically inside the pulp and whether our current clinical concepts truly reflect that biology. And our meeting will be divided into several sections. We've got several questions to focus on different fields of this topic. And the first one will be about the endpoint of VPT. And in your opinion, are we clinicians pursuing the wrong biological endpoint? I mean, should we stop thinking of mineralization as the primary goal of VPT and instead consider it one consequence of successful immune regulation?
Well, it's a very good question. I think inherent in that question, first of all, is outcome. As clinicians, we tend to be looking at an outcome from a perspective of the patient's symptoms, the radiographic findings, and perhaps the clinical tests. If you're a patient, you may look at it quite differently. You might look at whether the tooth is painful, whether it's costing you any more money to get it fixed, what might happen in the future, does it look good? And I think if you look to a third level of outcome, you might look to scientific outcomes. You might be interested to see how does the hard tissue form over the pulp, how healthy is the pulp tissue, how responsive is the pulp to the material that's been placed. So it's not an easy question. Very often we think of outcome in terms of simple, but in actual fact, what we really ought to be thinking about is how does the biology interact with the patient to maximize the clinical benefit? And at the moment, we're quite technical in dentistry. I think we all agree. We drill a hole, we remove a little bit of the pulp, we put a material in, we get a response, we evaluate it with something cold or a radiograph. But we don't necessarily think of how is the pulp behaving and how might I optimize that pulpal response? And I think that's something that's really going to be teased out in Vilnius is, can we separate scientific outcomes and can we make those scientific outcomes more relevant for clinicians? So that's important. And it brings in exactly what you're saying. It brings in immunological response. It brings in mesenchymal stem cell response. It brings in the role of mineralization and healing, all these sort of things.
Yeah, that's right. And maybe let's keep it more clinical and think about the clinical situation. And if two teeth both develop a hard tissue bridge, but one forms organized reparative dentin while the other develops irregular dystrophic mineralization, are those biologically equivalent outcomes in your opinion? Both will be a
Well,
success or there are
they could
differences?
be. It's a great question, Hubert, and they could actually be clinically equivalent outcomes because the reparative dentine with tubule formation, as a result of odontoblast-like differentiation, which gives a nice dentine bridge repair, we love to see that histologically. Of course, we cannot see this clinically. All we can maybe see on the X-ray is some mineral formation underneath the material, if we're lucky. So from a clinician and a patient's point of view, really we cannot tell them apart. Why we as scientists, when we're developing materials, become obsessed with this histological response is that the better the histological response, we tend to think the better the pulp is responding. So therefore, we think that's a healthier situation. It's true regeneration of the pulp, dentine pulp material. But from an actual practical clinical point of view, the biological outcome for the patient might be exactly the same. What I believe, though, is if we can form a better quality dentine or a better quality repair, I think that will form a more predictable outcome. Because if you have dystrophic mineralization, the chances of failure, the chances of inflammation, the chances of leakage are actually higher. So it will have a knock-on clinically, so it will have a biological effect, but from the vast majority of clinicians, it isn't evident. That's what part of the discussion will be in Vilnius. How important are these measures to a clinician? And why should they be important?
Good, good. And now let's focus on the role of the pulp and the material, what these two are to each other, for example. And as we know, hydraulic calcium silicate cements have transformed our clinical practice. However, your publications repeatedly suggest that these materials create favorable conditions for healing rather than directly inducing regeneration. And have we perhaps overestimated the role of biomaterials while underestimating the biological capacity and limitations of the pulp itself? Maybe we
Yeah.
think too much about material and less about the
Well,
pulp itself.
I think one of the reasons we focus on materials is because it's one of the things we can control. And it's also one of the things that industrial partners or companies can support us with because they can supply new materials. If you're to look at a hierarchy of what's the most important thing in vital pulp treatment or pulpal response to make it heal, I think the material isn't number one. I think the most important thing is the inflammatory infective state of the pulp. If the pulp is very inflamed or infected, the chances of success drop dramatically. What materials are good at doing is increasing the predictability of the response. Very few materials, in fact, none of the materials we really have are what you would call antibacterial. None of them will actually kill a biofilm. So we have to handle that as clinicians by removing tissue. Thereafter, the material might generate the response. So I think you're right. I think we tend to sometimes mistreat the pulp, treat it badly, maybe not get the diagnosis right, maybe not remove appropriate amount of tissue, and then hope that our hydraulic calcium silicate cement like biodentine or MTA or some of those materials will magically heal that pulp. I don't think the evidence is there to support that. I think what the material will do is if we get the clinical conditions right, in other words, we remove the infective tissue, we handle the pulp very gently and very carefully, and we irrigate the pulp properly to clean away any residual infection, the material will do the rest. But you are right, not the most important factor. The most important factor is biological control of the inflammatory infective condition of that pulp.
Yeah. And maybe we can a little bit expand this matter. And could the same material produce completely different healing responses simply because the host inflammatory environment is different? So the material is the same, but the response of the patient is different. Could the same material produce different reaction?
Yeah, this is great. This is a real focus of the sort of research we're doing in Dublin at the minute in my lab and other labs around the world. In fact, I'll show some of this research when I speak in Lithuania, because what we tend to see is we classically can see that if you use calcium hydroxide or use MTA, there is a difference in the healing response. That somehow we can accept. What we find less difficult or more difficult to accept is if we use biodentine in two teeth, you get different responses. And I think what we're seeing is the response to biodentine or MTA or any hydraulic calcium silicate cement is not predictable. Sometimes you actually get a really nice, almost odontoblast-like regeneration of a primitive dentine structure. Sometimes you get sort of dystrophic calcification with no quality of tubules at all. And sometimes you get next to no mineral. And this is using sound teeth, not even inflamed teeth, and comparing. So there's a range in the response to even the same material. And I think that ties into your previous question. It's not just the material that's important. It's how you handle the tissue. Even each patient may have a different healing response. Something we don't think about at all in dentistry is there a personalized response to therapy, which is, I think, in the future, moving beyond this year into the next 10 or 20 years, I think personalized response to medicine will become really critical in endodontics, I hope, because I think it's very, very interesting.
That's right. And now maybe as we started to talk about the inflammation process from the patient and from the host, one of the strongest themes throughout your research is that inflammation is not simply an obstacle, it is an essential component of regeneration. And where do you believe this threshold, the threshold lies between beneficial inflammation that promotes healing and the inflammation that irreversibly alters the fate of the pulp? When is the sweet point?
Yeah, we talk a lot about this balance between inflammation and repair. Inflammation, after all, is necessary for healing. You can't have really healing in the absence of inflammation. However, what we've seen from the histological work we've looked at is you have a sustained inflammation or persistent or high levels of inflammation, the chances of healing reduce significantly. If, however, you drill, for example, a sound tooth and you put a material against it, you will have a much better chance of healing. And there's very little inflammation in there. So my view would be that you need a little inflammation, not much, a little inflammation, and that will be enough to stimulate repair. I do not think we need a lot of inflammation in the pulp to stimulate repair. Because if you think about this, and we're thinking as sort of scientists here, if you look at an arm and you cut your arm, or you cut your hand, you clean it immediately to make sure it's not infected. You put some sort of bandage on that and you'd expect that to heal. It won't heal any better if you were stimulate a little bit of inflammation in there. There will be natural inflammation in there. So at all times we should be looking to limit the inflammation. There will be enough inflammation generally to stimulate repair.
And do you think maybe in the future we will be able to foresee the future? Do you foresee a future where we assess inflammatory activity biologically before we could decide whether to perform VPT procedure or maybe not? Will it be possible in the future?
Oh, I'd love this. I'm getting very excited about this, Hubert, because this is really exciting, because this ought to be what we're doing. I think in dentistry and endodontics, we're really quite primitive in our diagnostic tools. We tend to use cold things or hit things with mirrors. We don't think of it biologically. Could we look at biomarkers, for example, of inflammation, like interleukins or matrix metalloproteinases, things that have been looked at scientifically? Or could we look at other things? Could we look at the cytology? In other words, the type of cells we have in pulps. Could they be of interest, perhaps, in predicting the future? And all these things are things that could be done quickly in situ. In other words, dentist exposes the pulp, quick test, like a COVID test, if you like. You were very familiar with that in the COVID years. You could do something similar for the pulp. Or cytology, where you take a little bit of thing and you quickly look under a microscope. And with the help of artificial intelligence, and we always talk about the negatives of artificial intelligence could quite easily have a program that could help you give you a reading of these thresholds. So you talked previously about thresholds, and I think these chairside tests in combination with an artificial intelligence program potentially could give you thresholds that could tell you need to remove more tissue, high chance, high prognosis, don't need to move more tissue, or not suitable. I think we could hope for those sort of things in the future.
Yeah, that's right. So we can go on with another topic that will be directly with the topic that we are discussing today, so mineralization. And let's talk about extensive calcification, because clinically we often celebrate mineralization, right? But yet excessive mineral deposition may eventually lead to pulp canal obliteration or other structural changes that are quite hard to face. And should extensive calcification always be considered healing, or can it represent an exaggerated wound healing response? How do you see this matter?
Yeah, this follows on a little bit from your question about the balance between inflammation and repair, because too much mineralization is a problem for clinicians. And this is one of the big debates I've had with people who advocate a full pulpotomy, for example. Full pulpotomy is you remove all the pulp from the pulp chamber and you only keep the tissue in the roots. Then you replace a hydraulic calcium silicate cement and then you restore the tooth. Very effective treatment. One of the problems is that what will happen in the residual pulp is that calcification will happen in that residual pulp. And if it's quite advanced and the tooth then thereafter fails, it's very difficult even for an endodontist to manage that, to find those root canals, to do the root canal treatment. So in reality, what we're really looking for is a controlled mineralization. We want a mineralization, a surface mineralization which walls off the threat, but we don't want a mineralization which actually proceeds into the pulp, goes in deep into pulp, because you'll start developing pulp stones, you'll just start developing sclerosis, you'll start making the life of dentists not easier, but more difficult. And this is something I've been thinking a lot about recently, that when we talk about regeneration of a tissue, we tend to talk solely in dentistry about hard tissue regeneration. We talk about regeneration of dentine, regeneration of a dentine bridge. We don't really talk so much about pulp tissue regeneration, or the actual tissue itself, but it's also very important. You want to have healthy pulp tissue under a 2-3 millimeter layer of mineralization. You do not want unhealthy dystrophic mineralization leading into your pulp and sclerosis, because it's very unhelpful clinically. So although mineralization is good, only a limited amount of mineralization is ideal.
It will be far easier for us as dentists, also in the clinical practice, to deal with this kind of teeth. And now maybe let's focus a little bit on the X factor, so the operator, us endodontists and dentists who deal with endodontology every day in their clinical offices. And have we maybe underestimated the role of the operator? Which operator-dependent factor contributes most to failures despite excellent biomaterials? Because before we focus on materials, techniques a little bit, but what about the operator, this factor X that has great impact on the outcome?
That's a great question, Hubert, because if you look at the literature, you'll find that there's very, very little examining the role of the dentist, particularly in vital pulp treatment. There's some in root canal treatment where they talk about the technical quality affecting outcome of root canal treatment. Very, very little in vital pulp treatment. Yet I actually beginning to think it's the most important variable. We tried to talk about this a little bit in the ESC position statement in 2019 and again in the S3 guidelines in 2023, when we started talking about this enhanced protocol. In other words, to do VPT correctly, you needed several things. You needed magnification, you needed hydraulic calcium silicate cement, you needed irrigation such as sodium hypochlorite, you needed dental dam, rubber dam. And although we weren't saying it directly, what that's really saying is you need high quality clinical skill to do vital pulp treatment.
Experience and
you need experience, you need to take time, you need to be careful, because pulp is very sensitive to how we handle it. So the better you handle it, the better the result. And something we've quite clearly seen in our histological results is that if you handle the pulp well, you will get a better reparative regenerative response. So the role of the operator is quite difficult to measure, but it's of critical importance, because I think what's likely to happen when these pulpotomy studies, which we at the moment are carried out in universities or specialist clinics by people like you, Hubert, with microscopes and time and energy and enthusiasm, if you give that vital pulp treatment to the general population, some of which will not have time or interest or the materials, we may see a drop in the success rates. In fact, I'm absolutely certain we will see a drop in the success rates. These so-called effectiveness studies are really required because they will highlight the role of training, education, time, and remuneration in making vital pulp treatment successful.
That's true. That's true. And maybe a little bit compare repair and regeneration. Let's keep it repair versus regeneration, because regeneration has become one of the most frequently used words in modern endodontics. Like everyone is talking about pulp regeneration, but yet biologically, regeneration requires restoration of original architecture and function. Based on today's evidence, are we truly regenerating the dentin pulp complex, or are we still primarily facilitating organized repair, in your opinion? It's more like a repair, or rather real real regeneration, in your opinion?
Yeah, this is a focus of the lecture I'll be giving in Vilnius, because I think this is a really important point. If you look at that, and you'll remember this, Schubert, about maybe 15 years ago, this term regenerative endodontic therapies, or RETs, became very topical. And they were principally related to revitalization procedures as we would know them, but they could have been referred to stem cell-based therapies or even vital pulp treatment. And they were based on the fact that when we did these therapies, we were regenerating the dentine pulp complex. In actual fact, if you look histologically, and I think this has been made in several papers by Stefan Simon, Tony Smith, Annabelle Diogenes, what we're largely doing in those cases is actually just creating repair. And I think that's an interesting point, because then you immediately think, well, what is regeneration? Regeneration is a sort of replacement back to the native tissues. And this is something we've become really interested in the pulp, because we have stem cells there. We have a dental pulp stem cell population. We have an apical cell population in scaps. We have a periodontal ligament stem cell population. So you think regeneration should be possible. And something I've been very interested in is this sort of ongoing debate. If you put a pulp capping or a pulpotomy material against the pulp, do you see any evidence of regeneration? In other words, is it just simply a amorphous reparative bridge, or is there signs of regeneration? And this is something I'm going to show some slides and have a discussion with in Vilnius, because I think there are suggestions there may be some regeneration, maybe not predictable, but some regeneration. And why is that important? Well, it's important because I think it gives hope to this idea that we are actually part of a regenerative endodontic or regenerative medicine group, because medics, and I'm always jealous of medicine because they tend to promote things better than we do. They always talk about, oh, regenerative medicine, regenerative medicine. Much of the medicine they call regenerative is only partly regenerative and actually largely reparative. So they're not calling it reparative medicine because it doesn't sound as good. They're calling it regenerative medicine. So we have to understand what we're doing, but still embrace this regenerative movement, because I think patients like the idea of regeneration. They like the fact that we are at least attempting to take on board regeneration. So I think there's some there, but it's not convincing.
Good. So we've got only 30 minutes for our talk, about 30 minutes. So let's think about combining the past, the present time, and the future to just a little bit of give some kind of summary of our today topic. Because 20 years ago, the profession debated whether major permanent teeth should undergo VPT at all. Today, the debate is largely settled, right? And looking ahead, another maybe 10 years, which current concept surrounding pulp healing do you think we will realize was fundamentally incomplete or even incorrect? Is there any?
I think in the past, you're absolutely right. When I was a dental student, which is quite a long time ago now, longer ago than you, Hubert, obviously, they used to talk about the pulp being doomed. It was a doomed organ. This was a phrase that was used. It was actually published, a doomed organ. In other words, if you exposed the pulp carelessly or even traumatically, the pulp had to go. You had to do a root canal treatment. I think one of the biggest biological shifts we've seen in endodontics is that now we don't see the pulp any longer this way. We see the pulp as something that can be preserved, or part of it can be preserved, and we can keep it patients as part of a minimally invasive therapy. So that change to the current day has been really, really important. One of the biggest challenges we still have is that a lot of dentists still don't perform these things in practice. They understand that it's possible, and endodontists are particularly guilty of this because they make a very good living out of doing root canal treatment. They don't tend to do as much pulpotomy work or vital pulp treatment work. So fundamentally, this could be an issue moving forward. But I think if you look at the current day, and what we are doing right now, we're removing pulp tissue, some pulp tissue, we're applying some material and restoring the tooth. I think the thing that's got to change in the future, I don't think we're doing anything wrong, but I think if you think about what might be nice to change in the future, is that some of this predictive minimally invasive therapy we're developing makes life difficult for dentists if it fails. We've always made the point that it's difficult if you do a root canal treatment, that only some dentists are able to do retreatment well. Mm-hmm. The same goes for vital pulp treatment. If you do a full pulpotomy, we just described this, and you get mineralization in the root canal system and it fails, it's very difficult for a dentist to manage that. So we ought to be thinking Can we make it easier for dentists to manage? Is there ways we can use materials which maybe don't form as much mineral in certain indications? Or could we maybe even regenerate the tissue, the pulp tissue, into the pulp chamber if we were to do that? So I think that's going to be the shift, the next shift. The next shift is, how do we get these biological, minimally invasive therapies and make them more dentist friendly? And we shouldn't always be thinking about failure, but we should be thinking about how we manage people's teeth to get the optimal result. And I think that is the mistake we may be making at the minute. We are very much still a remove and replace, rather than thinking a little bit more cleverly on how we might actually manage pulp and dentine tissue.
And I think just to keep this topic in one sentence, I think that we can say that the best endodontic treatment is the conventional endodontic treatment that that could be done is the one that is not performed, right? That we benefit from the pulp itself and keep it vital as long as it is possible, because the biology is the best filling of the pulp chamber and the space of the roots, right, inside. And just to close, you've spent much of your career studying how the pulp heals at the molecular, cellular, and clinical levels. And if every clinician watching today could change just one aspect of their thinking about pulp healing tomorrow morning, what would you want the change to be?
I want the change to be that although dentists do not necessarily feel educated or trained in modern vital pulp treatments, is to go, do a course, think about how you might retain all or part of that pulp, and modify your clinical protocol to reflect that. In other words, if you have a young patient in, irreversible or reversible pulpitis or severe pulpitis in the tooth, just think, okay, one of these cases this month, I'm going to treat with pulpotomy. This is how I'm going to do it. You know they're skilled enough to do it. Let's see if I can do that one this month, and let's follow that case up. Because a lot of people are thinking about it, but not put it in their practice. And that's the one thing I'd like to see change. Not get the biological information and put it into practice. That's my advice.
I hope that for everyone, the topic that we covered today would be very informative and useful for your clinical practice and maybe for your university work if you are also a researcher. And right now we will give the voice to the people watching us, to the audience. So I'll just share a question, the first question that we've got. And here's the question. Hi, sir, which is the best material to use for mineralization of dentine?
Yeah, that's a good question. We would suggest that hydraulic calcium silicate cements, and what I mean by that is things like biodentine or MTA would be a classic example, or Angelus would be another one, or Dentsply have got a material. Most companies have now got a material. There are also some putties available, which are also hydraulic calcium silicate cements. For example, Wellroot or FKG have got a putty. We will show some evidence in the lecture in Vilnius, and I will highlight this, that these also form mineral, but maybe not as much mineral. So if we're talking about mineral, I think you're better with the material that mixes the cement with the water at chairside rather than the form of a putty. But certainly all those materials are better than calcium hydroxide or any other material you might use, like composite or something else. No, those materials aren't very good. So hydraulic calcium silicate cement, ideally water and powder mixed at chairside.
Good. That's good. And I will see if there are any other questions from the audience. And for now, I don't see any. Maybe there will be in the future in the comment section, if there will be. I hope that you will get your answer in the future and on other date, not today, because we are live right now. So if there are no questions more, I think that we can slowly finish. So thank you very, very much, Hal, for your time that you shared with us today. And I hope that we'll see each other and with everyone here watching us in Vilnius this October, where this topic will be covered in much more broader portion than today. There will be more time, and I wish you pleasant evening, morning, afternoon, wherever you are, on whichever or in whatever continent. Also, thank you very much.
Thank you, Hubert. Thank you.
Bye.
Bye-bye.